gamma knife is more comfortable because the couch of Elektra is more comfortable than lying on the MRI couch.
Actually, Fritz Mundinger and Richard, they did not like Cooper, and so whenever I mentioned Cooper, they said, Cooper, and we did it before, or something like this. And,
Okay.
And I think maybe it's true, yeah. And Richard was a good friend of Spiegel, and Spiegel visited Freiburg, and Richard visited Spiegel, and what they said is that they did the first thalamotomy years before Cooper, by an act of serendipity, used the thalamus as a target by himself in 1957. And also, pallidotomies were done already in the late 40s, and they spread all over the world already in the early 50s. So when Cooper had this happening during the surgery for a pallidotomy, where he severed the anterior choroidal artery, and he observed lesion in the pallidum. The atactic pallidotomies were already routine, were in place in several other instances.
He was attacked in a letter to the editor by Spiegel and Weisses. They attacked him in a letter that I would send to you later. I don't know if Joachim has the letter, published letter. He was attacked by Spiegel and Weisses for plagiarism. They attacked him that he has plagiated their frame.
Welcome to Stimulating Brains.
Marwan Hariz and Joachim Krauss need no introduction. First, because they are famous, and second, because they have been on the show before. In fact, Marwan Hariz is the first to have been on the podcast 3 times. First, as an early adopter and trustee in episode 3. Second, together with Joachim Krauss and Christian Moll in episode 33. And now again with Joachim in the present episode. I met Joachim in Grenoble at a meeting celebrating the 30th year anniversary of STNDBS. He mentioned that the last episode had been fun and that it could be great to do an episode on the history of pallidotomies. Needless to say, I would always spend as much time as I can get speaking with these legends in the field, so of course we went ahead with the idea. But to demonstrate just how busy both of them are, we planned this in summer 2023 and only now got to it. I think there are few people around that know as much about the history of stereotactic surgery as Joachim and Marwan, and in fact recently they have been designated as the historians of the ESSFN and also of the WSSFN, the latter together with Rhys Cosgrove. In this conversation, I learned that pallidotomies came in 2 waves throughout history, and we may be witnessing the 3rd wave now with the growing popularity of MR-guided focused ultrasound surgery. So sit back and enjoy while Marwan and Joachim take us on a ride through the centuries to shed light on the convoluted historical path of the surgical procedure we call pallidotomy. So thank you so much, Joachim and Marwan, for joining again. This is, of course, a big honor to be able to talk to you again as 2 of the most knowledgeable people, not only as surgeons, but also about the history of neurosurgery and neuroscience. And I think we thought about, together this came up to do an episode about pallidotomies, which may have been a forgotten art, but seem to come back and have already had several comebacks in the history, or 1 comeback in the history, which we'll cover. And so this is obviously not a topic where I'm very familiar, but you are. So I hope we can learn a lot from you guys. You just wrote me in an email that you both are the official historians now of the WSSFN. Is that correct?
Yeah.
Yes.
What does that involve as a job?
Correcting the mistakes of other people.
And sometimes seeking out old manuscripts and see that several issues have already been raised decades ago and sometimes being solved also. Yeah. Great. Yeah, I read your fantastic chapter on pallidotomies that you sent around, Joachim, and there you write the same thing, right? That when it
came back, there were a lot of things that had already been considered back in the day, and I think we often have that now with focused ultrasound as well, but even in almost everything. Even Haggai Bergman in his book wrote that he later discovered that 30 years ago there had been another person that had already talked about the role of histamine in the basal ganglia and so on. So there's always these rediscoveries, and it's really worthwhile to study history for that reason. I totally agree. So I think we've both been on the show before. Usually I ask about hobbies, but we've covered that before, so we can jump directly into the science. And Marwan, in your 2022 Serendipity article, which we had also talked about before in stereotactic and functional neurosurgery, you recount the tale that one of the 6 patients originally described by James Parkinson had a stroke, which led then to the alleviation of tremor. And in the early 1900s, this, among many other reasons, led to surgeons aiming to mimic stroke using ablative surgery, mainly to treat tremor, I think, but also atetosis and dystonia. And surgical procedures for this paralysis agitans or Parkinson's disease, they did consist in most part in creation of lesions of the entire corticospinal system. You also write beautifully about that, Joachim, in your chapter. So the motor cortex, the spinal cord, anything in between had been lesioned and tried. I think, Joachim, you even wrote that for ballism, there was even the idea to amputate limbs, right, as a recommendation, which is, of course, very drastic as well. And I think all of these procedures, rhizotomies, anterolateral chordotomies, pyramidotomies, pedunculotomies, and so on, they usually went into improving the symptom, but also losing function with paralysis of the limb. I think Paul Bussy even ablated areas 4 and 6 in individual cases, which also led, of course, to paralysis. So we want to focus on pallidotomies today, but before we go into that, could you maybe summarize a bit about these very early days of ablative neurosurgery? Is it possible to derive at an executive summary of this earlier area?
Okay, I can start a little bit. The first operation for Parkinson's disease was done in 1912 and published by René Le Riche. René Le Riche is a famous general surgeon who also trained Pierre Wertheimer, who is the neurosurgeon in Lyon, who gave the name to the hospital. The hospital in Lyon is by the name of a neurosurgeon. Anyway, René Le Riche is on a stamp, postal stamp of the French postal stamp. So what he did is posterior rhizotomy of C2 to C8, C2 to C8 to cure tremor. Well, it didn't work well, and that was the first operation ever published for Parkinson's disease. Then you jump many years, and then it's operations on the motor cortex. And I think it was Broder who started, and he wrote a paper where he said it is impossible to cure tremor without provoking paralysis. Mm-hmm. That was his conclusion. And then it is told by Blaine Nashold, who is a grand old man of American functional neurosurgery, that at that time they were doing mostly functional neurosurgery for psychiatric illness, as you know. And during leucotomy or lobotomy, Broder went very far medial, so he cut the head of the caudate. And the patient had psychosis, but also Parkinson or tremor, and the tremor was cured. And this probably is why Russell Meyers thought, maybe we should start curing Parkinson by taking away the head of the nucleus caudatus. And it started from this, and then he went more deeper and deeper and deeper.
So Marwan, sorry to interrupt. Let's go into that in the next question. But how about maybe can we summarize also the pyramidal system lesions that were before Meyer's time?
Maybe maybe I can add something on dystonic movement disorder. So, as far as I found out, I think the first cortical lesion for atetosis, or it was called at that time, was actually made by Sir Victor Horsley. And maybe that was in 1890. Because there are two sources. Yeah, one is a publication from Horsley, which is called Remarks on the Surgery of the Central Nervous System, published in the British Medical Journal in 1890. And the other one is a clinical lecture on the function of the so-called motor area of the brain. At that time, it was so-called motor area. Yeah. And this reports I talk about a patient with atetosis, and they thought the atetosis started after some peripheral surgery, and he went ablation of the cortex. Yeah? So that was the first source I could find of cortical ablation. Yeah? Before it was applied to PD or Parkinson's patients.
And Joachim, you're also a neurologist. I think that's not widely known, but is atetosis really the same thing as modern dystonia? I don't know that myself. I always wonder. It seems similar, but because now we use atetosis for specific symptoms.
Yeah.
But at the time, you never find the word dystonia in these early reports, and my feeling is that when they speak about atetosis, they mean dystonia. Is that correct? Or
well, I would say they mean basic dystonia, mobile form of dystonia, but not really regarding the posture. On the other hand, we have some early photographs where they show choreatetosis of the hands also, and you can clearly see dystonic postures of the fingers. Yeah.
Okay.
But I think atetosis, especially the term choreatetosis, was coined to describe more the mobile part of the disorder.
Okay. Great. So again, many systems of the pyramidal system from motor cortex down were lesions, and that had been done for how many years before we touched, or surgeons touched the basal ganglia? Was it at least decades, right? Where before, because my understanding is that the basal ganglia were considered, for example, were considered the seat of consciousness, so lesioning them for a long time was a no-go. I think they were called noli me tangere, as you write, Marwan. So a structure not to be touched, and then essentially it came about as an accident. And you were just about to describe that, Marwan. Maybe you can continue there then.
It was Walter Dandy, the neurosurgeon who invented the ventriculography in 1918, who said that you should not touch the basal ganglia. Why he said that? Well, because he thought it was the center of consciousness. And that was one of the reasons why Spiegel in the beginning, and he described that, was very keen on or very fearful to do the pallidotomy, especially on both sides, because they were afraid of
coma, right?
And as you know, in carbon monoxide intoxication, you have affection of both globus pallidi, the whole, and the patient is in coma. I think Joachim knows more about this.
Yeah, it was one actually of my early manuscripts was on disulfiram intoxication reducing pallidal lesion with subsequent Parkinsonism and dystonia.
And so did these also played a role in the surgical history, right? That these findings post-mortem, that after intoxication you had lesions in the pallidotome that led to Parkinson's disease. Is that correct? Did that play a real reason to better understand things?
Yeah. Remember that the open surgery of Russell Meyer, Guillot, Fenelon, with different approaches, transventricular, subtemporal, or transcortical, were aimed at the ansa lenticularis expressively. It was not pallidotomy, open pallidotomy, it was ansa lenticularis. How they found it, without frame, without radiology, without open. I have big admiration. We have hard time to find it now with MRI and tractography and everything. But that's what they aimed at. So they didn't aim at the pallidum. They aimed at the outflow of the answer. Right, Joachim?
Yeah, and there's some report in one of Mayer's manuscripts from 1949, and they used kind of a transventricular approach with an angulated probe. And what they say is they went to the answer, as you just mentioned, Marwan, and they also tried to extirpate the oral pole of the globus pallidus. So they did not really go to the what we now call the sensory motor area, but they were definitely more anterior, and in the anterior part, lower, more ventral, initially.
Great. So again, to summarize, the first incident to touch the basal ganglia was probably Jefferson Browder's case that excised the caudate that you just mentioned before. And then likely following that, Russell Myers, I think in 1939, operated on a 26-year-old patient with a likely diagnosis of post-encephalitic Parkinsonism, and he used a transcortical transventricular approach. Beautiful picture of, I think, that approach in your book chapter, coming from medially through the ventricles, I think, right? Myers resected the anterior 2/3 of the head of the caudate nucleus. Reading that now, my feeling is, head of the caudate, I always think of the putamen of being the motor part of the striatum, and head of the caudate more cognitive or so, but it seemed to have helped, right? Striking improvement with complete cessation of tremor, except when the patient was emotionally excited, that the patient was emotionally excited. Sorry, there was still tremor when the patient was emotionally excited. And this established for the first time that it was possible to improve Parkinson's symptoms with a surgical procedure that did not produce paralysis, right? So that was a real breakthrough, I think. And then, this went through the roof with a case series of more patients. Maybe you can tell the story of Russell Myers a bit more, if possible.
No, you do it.
Yeah, well, I must say, I was fascinated to read these papers by Russell Myers. And I read many of his articles. I never met him, and he actually was a little bit ignored in the functional stereotactic neurosurgery scene initially. And I think he was only discovered later, but he never had a firm position in history for functional stereotactic neurosurgery only until later, when they really discovered his pioneer work. And as far as I understand, he also abandoned functional surgery at a relatively young age, in his 40s or so, and I think later he did not engage any longer in these types of surgery. Also, especially the early functional neurosurgery, the open approaches, somehow followed his targets, but with different techniques.
The concept of functional neurosurgery was coined by Pierre Wertheimer from Lyon, again, in a book in 1952 or 56. That's where the first time functional neurosurgery is coined as a category. But remember, Andy, that almost all neurosurgery in the 20s, 30s, 40s were psychiatric surgery. So it was not aneurysm in the beginning. It was not, there were attempt, of course, at aneurysm surgery, pituitary surgery with the Harvey Cushing, but most of the early neurosurgery was either traumatic for after World War I down to World War II, and lobotomies, different kinds of leucotomies. So that was, and they didn't call themselves functional neurosurgeons. They were general neurosurgeons, operate anything that could be operated. So that's, I agree with Joachim. He was not a functional neurosurgeon, Russell Myers.
Got it. And I think that's a very important point, that both of you highlight every now and then in your papers that the entire stereotactic surgery field comes from psychosurgery, essentially, right? We discussed that in the last episode as well. I think it is still true that a lot of cases, or maybe not a lot, but there were early cases with Huntington's as well, right? I think Huntington's was what seemed to be a prominent diagnosis to do surgery in these days, but then also, of course, as we mentioned, Parkinson's and atetosis as well. I think I also learned this from you, Marwan, that the first DBS maybe ever that you mentioned in 48 by Poole was, I think it was for psychiatric symptoms, but it was a lady with Parkinson's syndrome.
It was several, but the first lady had some psychosis, and funny enough, the target was the head of the caudate.
Yes, yes. Interesting. Okay, so I think one issue in Meyer's approach, and also in the 58 cases that he operated between 39 and 49, all from your excellent work, was the high complication rate, right? Because of the open transventricular surgery, I think up to 40% mortality rate, as you write. What followed in the attempt to improve that?
Shall I say something about Fenelon?
Yeah.
All right. So, in the late 40s, the French neurosurgeons, I think, were inspired also by the work of Myers and Crowder, and they started to target the basal ganglia and also the pallidum and pallidofocal pathways by different approaches, not transventricular. So Fenelon had two approaches, one temporal approach to go to the basal ganglia, and he also later applied a transfrontal approach. So trying to avoid some of the earlier complications. And I think 2 or 3 years later, Guillon and Briand, two other French neurosurgeons, they modified the technique, having a subfrontal approach and a transsylvian approach. And they started to have open approaches for placing lesion in electrodes. But that was in parallel to the development of stereotactic surgery already.
The aim was all the time to decrease the morbidity. I mean, the all efforts, in my historical opinion, were concentrated on more and more pointing to the target while avoiding the side effect. In any, you can start with lobotomy, which is different kinds, and then for movement disorder, and then all this converged until stereotaxis was invented, which was the ultimate tool to avoid the harming the rest of the brain, right? So this is how it came about, and all these different techniques that Joachim mentioned is how to get to the area of interest without harming the rest of the brain. This is the essence of neurosurgery, and even more the essence of functional neurosurgery, but also the essence of general neurosurgery. How to get to the aneurysm without opening half the head, how to get to the tumor. Sure. So it's the essence of neurosurgery.
In that line, maybe focused ultrasound or gamma knife could be seen as another way to do that, right? In the same line where you try to spare an open approach. Of course, with all the downsides, and I know that's a bigger topic, but at least it's an attempt in the same direction, I think.
Yes, we can discuss that later. It's I'm not sure it's better than
No, I get the point. So I think around that time we should mention Cooper performing the pedunculotomy and then the accidental lesioning of the anterior choroidal artery. Can you maybe talk about that, Joachim or Marwan?
Joachim, he better to talk. He doesn't like Cooper.
Well, that's not completely true. I mean, I was raised, so to say, by Fritz Mundinger in my functional neurosurgery childhood, and actually Fritz Mundinger and Richard, they did not like Cooper, and so whenever I mentioned Cooper, they said, "Ah, well, Cooper," and we did it before or something like this. And
Okay.
and I think maybe it's true, yeah. And so Richard was a good friend of Spiegel, and Spiegel visited Freiburg, and Richard visited Spiegel, and so what they said is that I think that is a historical fact, that they did the first pallidotomy in 1952.
Okay.
Years before, Cooper, by an act of serendipity, introduced the thalamus, or used the thalamus as a target by himself in 1957. And also, pallidotomies were done already in the late 40s, and they spread all over the world already in the early 50s. So when Cooper had this happening during the surgery for a pedunculotomy, where he severed the anterior choroidal artery, and he observed a lesion in the pallidum. Pallidotomies, the tactic pallidotomies, were already routine, were in place in several other instances.
That's very interesting to know. Yeah, because it's often really the good marketing, right? That may write the history.
Absolutely.
Yeah.
No, it's not only that. It's also the fact that as Joachim wrote, the papers from Germany were written in German.
Mm-hmm, yes.
The papers from France were written in French. And the papers of Cooper were written in English, of course. Mm-hmm. But the advantage of writing in English and coming from the United States mirrors the influence of that country, the United States of America, growing up between World War I and World War II. And of course, after that. So what is coming from the States until to this day weighs more than what is coming from Germany and France. Although the big pioneers of the United States, like Pat Kelly, Gildenberry, and others, they visited Europe and they learned from Europe. Jules Hardy from Canada, who went to Albert Fessard and Guillot, Pat Kelly, who went to Talleyrand, Gildenberg, who went to Freiburg.
Penfield was with Förster, right?
Yes. So they come here to Europe, they learn from Europeans, and well, Cooper didn't come here, but the point is, what is published from where you live now carries heavy weight internationally, more than what is published from Germany or France or Kandahar in Afghanistan. Although the latter may be more correct, but this is another story. So this is one of the reasons why Cooper is credited to be the inventor of thalamotomy, which is wrong, of course. And by the way, I was very sad to learn, Joachim, that the first paper on thalamotomy from Freiburg, the operation was done by Mundinger, but he was not on the paper.
Yes, absolutely.
This is unexcusable. What happened?
Well, that's another interesting story, Marwan. So I found the operative report. I still have to publish it, yeah. And it's clear that so it started. The idea started from Hassler, because Hassler had his theory of the thalamus, the motor thalamus, and so on. And so Hassler came up with the idea to target the thalamus for treatment of tremor, yeah. And Mundinger was a young resident. I think he was in his second year of residency or third year. And he was a surgeon to do this thalamotomy. And in Freiburg at that time, they already had a series of pallidotomies. So they switched to thalamotomy for treatment of Parkinsonian tremor. And when the paper was published, residents at that time had no right to appear as co-authors on a manuscript. And I must say he was very frustrated about that fact. And he was frustrated even 50 years later.
Wow. Yeah. Understandably.
Yeah.
Joachim, how much older was he to you? Like when you trained with him or with the Freiburg team, what was it? Was it a generation between you and them?
Absolutely big generation gap. So Professor Mundinger was born in 1924.
Okay.
So when I joined him in 1987, I was a very young guy, and Professor Mundinger was a big senior figure, and so that was very impressive for me.
And still angry about the fact. I could understand that. Yeah, it's of course, yeah. It's fascinating to me also in general, the story of Rolf Hassler, because he was not a clinician, right? He trained with the Vogts. He was a pathologist, as I understand, but he did not treat patients. But he still seemed to have been very influential on the team. Is that correct? So he was not a neurologist and not a neurosurgeon, but he seemed to have played a key role.
No, you're right. I mean, they had a fantastic team in Freiburg, and I had an interview with Professor Mundinger in 1998 about the history, and he told all of the history that is actually lost in the meantime. And it was a department because Freiburg was completely destroyed in 1944. And so all of the institutes were gone, and they built it up very slowly. And there was Behringer, a psychiatrist, and he built up the team of neurologists and neurosurgeons. So with Richard Jung, and he had Hassler on board, and so later Richard came and Mundinger came, and so Hassler had a big influence with his anatomical studies, and he laid the grounds for much of the basal ganglion network, which we understood only later. The network idea really, because first, of course, it was morphology and some connectivity, and I think. I mean, when you look at it, his nomenclature for the thalamus is still being used today, although it's outdated.
Yeah. It's in the Schaltenbrand-Waren Atlas, right, as well, yeah.
And when you still will use it, so quite remarkably.
Maybe as an anecdote that goes into the same line of what you just said, Marwan, with the carrying weight of the US and so on. I had the big honor that Mahlon DeLong visited me here at the Brigham recently, and we talked about earlier times, and I also showed him these quite early studies of the Vogts and Hassler from the striatal system, I think from 1920, where a lot of the loops were already anatomically at least identified, and he was fascinated at that time. So I think he was not aware, at least currently, that this had been known so early. And then, which is another way of, similarly, I think these publications were in German at the time, right? So just hard to find as an American. And then I also found it quite remarkable that he told me that he met Rolf Hassler at some point at conferences, and he seemed like a very dominant figure. I don't know if that matches your...
He was extremely dominant. I mean, the two German most dominant figures are Rolf Hassler and Schaltenbrand.
Okay.
One from Würzburg, right, who was succeeded by Volkmann now, in a way, and then Hassler. And remember, Hassler is connected so much with Freiburg, but Hassler published also with Gerd Diekmann on psychosurgery from Homburg-Saar. I don't read German, unfortunately, not so much. But I have followed the German school, and it's fascinating how this man was like the center of all stereotactic and functional neurosurgery in Germany, and not only in Germany. So maybe I don't know if he published also with people from Göttingen, but at least with Gert Diekmann, he has papers on Tourette and on psychiatric surgery, right, Joachim?
No, you're right, Marwan. And he moved from Freiburg then later to Frankfurt and had his own institute in Frankfurt. And I tried to contact his daughter, who was taking care of the remains of the institute, to get a brain of a patient with hemibalism, but actually I don't know what happened to this institute in the end. If it's still there, if it's a kind of museum, if you can go there, but he was very influential on many other people.
Okay. So I think we've diverged a bit, of course, to go back to pallidotomies and the history. I think we had been talking about Cooper. I learned that he did not invent pallidotomies. I think in parallel, stereotactic procedures were developed. I think as a consequence of the 1936 Nobel Prize winning work of Egas Moniz with leucotomies in the treatment of mental illness, that were originally, I think, celebrated, but then had a lot of side effects, were very extensive. So we have already talked in the last episode about Spiegel and Weisses, and you've mentioned Spiegel before, who I think in 1947 carried out the first stereotactic procedure. 1 year later, in 1948, they performed a pallidotomy in a patient with chorea Huntington with the rationale, and I'm quoting again, of course, Marwan's great papers here, with the rationale to tackle the output structure of the extrapyramidal system. And then following these reports, I think several frames were designed by Teilarak in Paris, Lexel in Lund, and Richard in Freiburg. So that was the dawn of stereotaxy. I think before, maybe to briefly mention it, I think 3 decades earlier, Horsley in Britain had already created a frame, but only used it in animals, just to give credit to that. But the first human application of stereotactic frames was by Spiegel and Weisses. So can you talk about this time a bit? What were the developments? Who were the key players? And maybe I think that was also when pallidotomies started, right?
Yeah. I think so. At that time, every neurosurgeon who respected himself created his own frame. I have a list of all kinds of frame, with all kinds of the one with the bar hole anchored to the bar hole, the one like this. So they created the. So I am quoted by Glenn Nashold in one of my papers, where I said the history of stereotactic surgery is to a great deal the history of its stereotactic frame, because they publish a lot of the frame, and they used of course ventriculography or pneumoencephalography, and all of these were shifting towards the movement disorder, because already at that time lobotomy and psychiatric surgery was declining, not disappearing, but declining, because of other things. And also every neurosurgeon with self-respect had his own target in the pallidome. I have a map of the pallidome showing the targets of about 20 neurosurgeons and 20 different. I have forgotten few of them. For example, Leitinen's pallidotomy, that is Lexel, that we will talk about later, was roughly the same target as Roeder and Ortner in Göttingen, which I published together with Wolfgang Hamel and Moll and Paul Crack in a paper, and it was that discovery, because they have seen the autopsy of the patient. It was almost the same target as Juan Bursaco in Spain that Joachim mentioned in his. And you have everything from the most anterior dorsal pallidome, which was Cooper and Narabayashi, to Lexel and Bursaco, and everything in between. Mm-hmm. Now, it's a little bit like today's DBS, because the lesions were so big that they could take everywhere. It's a question of of who has the best stereotactic frame, because the aim was to also to manufacture and to sell these frames. I mean, there was an economic incentive, right?
Okay.
So you have
So they were entrepreneurs. Okay, I did not realize that.
Yeah,
okay.
Electa, for example, was a company founded by the sons of Lexel, of Lars Lexel, which still exists today with Gamma Knife and frame. And you have companies with the Richard Mundinger frame. You have companies with before with Talleyrand frame. So there was a kind of incentive. I'm not saying that this was their main aim, but this was also in the picture.
Okay.
Maybe I can add something on target choice in the pallidotomy in the early years. So as you said, Marwan, everyone had somehow his own target, yeah. And there was one analysis by Levy, published in 1959, and he came to Freiburg also, and he looked at the different targets, and he very nicely depicted the targets of different neurosurgeons on anatomical sketches. And so there was another neurosurgeon, French neurosurgeon, Raymond, and Raymond had the posterolateral lateral GPI as a target. Yeah, I think he had been completely forgotten and neglected as well. And at that time, many people went more to the anterior pallidotomy. And of course, it's not because we now tend to glorify some ancient times. Sometimes we say, well, this was a big period of pallidotomy and everything worked, but that was not the case in every place, because some neurosurgeons had better results and some had worse results, and those who were targeting the anterior pallidum in general had less favorable results.
Yeah. In your book chapter, Joachim, you show also the map by Hassler with the homunculi in the thalamus and the pallidum, and to me it looks like, it starts in the posterior lateral part with the legs and then goes up to the very front head of the pallidum as the head of the homunculus, and I think that doesn't make too much sense anymore with modern days, right? The motor part of the pallidum should be smaller, and the front is psychiatric or limbic and associative, I think.
Well,
right?
you're absolutely right. I've seen dozens of maps of somatotopy in the pallidum. They all look different, upside down. And well, I mean, you should know better. What is the somatotopy now of the GBI?
I agree with you. I mean, there are not so many good maps, right? I've seen probably 3 or so, at least in more modern times. And I think there is an organization. Sorry, Marwan, you have some.
There is an organization, because when we did a lot of pallidotomies with Leitenen and after Leitenen, when you go with the probe down and you stimulate, you can provoke dyskinesia, which is a very good sign, as you yourself have heard from Rhys Koskorov with your discussion.
Yeah.
The first dyskinesia appear in the leg, and then you go down and down. So the homunculus, according to macro stimulation, is leg up, and then arm and the head most down. So this has been repeated times and times again, just by provoking dyskinesia in the off-medication patient on the table, which is a very good sign for the prognostic.
Yeah.
So the map of Hassler is upside down.
And it's also, his is a bit more in the AP plane, right?
Yeah.
So, okay. Okay, great. So in, you mentioned Narabayashi, and I think we should also mention him. You write that he was somewhat isolated from the Western world, but developed very similar concepts. Shall we maybe briefly talk about Japan?
And he was attacked in a letter to the editor by Spiegel and Weiss. They attacked him in a letter that I will send to you later. I don't know if Joachim has the letter, published letter. He was attacked by Spiegel and Weiss for plagiarism. They attacked him that he has plagiated their frame.
Oh, wow.
And he answered the letter with another published letter where he said he's not plagiating anybody and he respects their work. And he was very nice Japanese honest and polite reply. And also, he mentioned, I think, that he was isolated. It was after 2 atomic bombs on Japan, in the early 50s, and there was no PubMed, no connection. But he was still aware of their work in a way, but it was not plagiarism. And these 2 gentlemen, Spiegel and Weisses, attacked the man for plagiarism. Can you imagine that? Do you have this letter, Joachim?
No, I don't have it. When was it published, Marwan?
It was published long time ago, in the 50s. But I will find it. I will try to find it.
Well, I had the opportunity to talk to Nagabayashi, and I asked him about the origins of pallidotomy, and he also the first indications for him were atetosis again. So we come back to atetosis, and Nagabayashi was not initially did not start as a neurosurgeon also. So
1956. I found the letter. 1956.
1956. So according to his personal account, he started in 1950, 1951.
Yes.
And at that time, I think he had really very little access to medical literature. I mean, not like we today, we can go to PubMed and we see everything what has been published last week. And I think they couldn't see what had been published last year.
Yeah.
You also wrote that that Nagabayashi injected procaine hydrochloride to obtain a reversible predictive effect of pallidal blocking. And then I think a mixture of oil, procaine, and wax to create permanent lesions. Maybe we can talk in general a little bit about chemical lesioning. Who did it? How was it? Sometimes reversible, sometimes because I don't know anything about that topic, to be honest. Was that something Nagabayashi pioneered, in your opinion, or was it used worldwide in multiple centers to use chemical agents?
I don't know. Joachim, you know better.
Well, I think, as we said before, there were different stereotactic frames. I think also many neurosurgeons had their own lesioning methods. Yeah, so
sure.
Some use balloons, some use cryosurgery, some use electrolytic lesions, thermo-controlled lesioning, ultrasound, mechanical lesions, small knives, rotating knives.
Yes.
I think there was Cooper, for example, used a substance called etapolin, which was mainly alcohol, 95% alcohol. And I think especially in the early years, in the early 50s to the mid 1950s, there was such an abundant way of different lesioning types. When we look at what we have nowadays, this is extremely limited. Yeah. But of course, the problem was that with many of these techniques, the size of the lesion was only poorly controlled. Do you agree, Marwan?
Yeah. It was only on autopsy that you can see. And Marion Smith also published a very nice paper in Journal of Neurosurgery about autopsy. She was a pathologist at Queen Square, and she showed autopsy of patient who eventually died and showed the lesion all over the place. And she even write that she put into question when the surgeon said the excellent results when the patient died 2 weeks later. She published that in Journal of Neurosurgery. Yeah.
Okay. Right. So in 1958, Spiegel and Weisses then published a series of 100 pallidotomies. I think you mentioned this before. The ansa lenticularis was targeted by many. I think we had terms for ansotomy, but also Forel-H-otomy, right? By others. Is it the same idea? Always the pallidal outflow tracts. And then I think their approach had evolved to the use of intraventricular rather than bony landmarks. And apparently in 77% of their patients, it was possible to either abolish the tremor or to reduce it considerably. So was that a landmark publication with the 100 cases do you think at the time?
The issue, I think that this is a landmark in a way that they published this pallido answer, but at the same time, some people did even lesion attacking the fasciculus lenticularis across the internal capsule. Even Cooper has published that, claiming that you can do lesion in the internal capsule if you can target that fasciculus without provoking paresis, which is can be questionable. And then after the pallidotomy of the cases of Spiegel, I don't know if it's after or in parallel, they did what you call campotomy, campus forelli.
Yeah.
So the forels. So what is the issue and the concept at that time, which we think today that we have discovered, is it was a circuitry surgery. And this is, I try to say in my meeting and in my publication, that the concept of targeting a circuitry is not new because of the tractography. People knew the circuitry.
Of course.
Even since Vogt in Germany, the pathologists Vogt and others, they knew the circuitry between the cerebellum and the thalamus and the pallidum and the thalamus. And they knew it. They couldn't see it like you can see it today, probably, but they knew that there is a pathway, a circuitry. The same goes for psychosurgery. While Excel did capsulotomy, anterior capsulotomy, from the prefrontal cortex or the limbic cortex.
Of course, it's
so this concept was existing, and the aim point was where to target to have the best effect with the least side effect.
Sure.
And then it went to zona incerta area, what Kernan called the DRTT, which is actually a cerebellothalamic DTT, and this is in the funnel between the STN and the nucleus ruber, going up to the thalamus, VIM, VOP, VOA, or VO, where you have many things. You have extremely many things, which is amazing that people can target that area without so many other side effects, because you have the medial forebrain bundle go there, the lemniscus go there, more anterior, the motor from the pallidum go there, from the cerebellum go there. So this concept of circuitry is nothing new. The new is that we can see it, or part of it, or we think we can see it. We think we can see it.
Yes, exactly. Yeah, no, I very much agree. And in my papers, so I had to learn that. I my early papers would not mention that, but in the newer ones, I usually add that too. So 100% this.
And in your book,
and I think
in your book too.
Yeah. So I think even in the very early days in 1800, people already tried to segregate systems in psychosurgery, right? And you mentioned, of course, Lexell in the 50s with capsulotomy to also cut connections in the brain. That was, I totally agree. So then I think I just mentioned Lexell, and he's next on the list. Again, this is very inspired by your great paper. So variable results led the team of Lars Lexell then to compare optimal lesioning sites within the nucleus in 81 cases. The optimal site was the posteromedial aspect of the GP internus, so GPI, anterior to the internal capsule and 16 to 24 millimeters from the midline. This led to Lexell's posteroventral pallidotomy. Do you still agree with these coordinates in general, by the way? The two of you?
I think that Joachim has published a lot about that, not only in the paper that he sent, but he also has a paper not long time ago about Sven-Nilsson, the paper of Lexell Sven-Nilsson, which has been reproduced again in movement disorder clinical practice, although it was published in 1960 in a psychiatric journal. But the interesting thing with this is that Lexell has moved his target. He started anteromedial and he went back and down and back and down and back and down. And it is stated in that paper that the best results were where the lesion were most posterior and most ventral in the pallidum.
Okay.
The other interesting thing with that paper is that there was no UPDRS and a cohort of patient before and a cohort of patient after. There was individual cases, 81 individual in a figure with the rating of tremor and rigidity before and after. And you could see how many got better, how much better, how many did not get better, how many got worse. Which today you have no idea when you have a mean value here and a mean value there. You cannot tell the patient anything. I can tell the patient that in experience 10% of patients did not get good results based on individual cases. But you cannot tell that in when you have this mean before and mean after. And not only that, in that Sven-Nilsson paper, they have also quality of life. They have go back to work or not go back to work for those who had work. It's extremely many details that, thanks to Joachim, were discussed in a paper specifically about this. Right, Joachim?
Well, I always wondered why I was commissioned to write this paper. And I thought maybe you should better have written it. So, but they asked me, the editors asked me to reflect on Sven-Nilsson's theory. So I wrote this manuscript. And I must say, this is really a landmark paper. It was published in 1960. And at that time, it was not really very well distributed, I think. And I think the most fantastic issue with this manuscript is that they were the first to explicitly describe the improvement of bradykinesia. Because they clearly talk about mobility, they talk about precision movements, speed, and so on. Because before, the main symptom for pallidotomy in Parkinsonism was rigidity. So rigidity was clearly the dominant target symptom for pallidotomy. Tremor also improved, but the best improvement, of course, was seen for rigidity. And then many people thought that the slowness of movement also improved. And when I prepared now for this podcast today, I've looked at the old doctoral thesis from Munding, and I found something which is really amazing. The thesis now that I found published by Reinhilde Brass, now the Freiburg, 1964. And she says, die scheinbare Besserung der Akinese müssen wir mit Skepsis betrachten. So she says, the apparent improvement of akinesia, 1964, we have to be very skeptical about it. And then she says, because akinesia is negative symptom, and this is related to improvement of rigidity. So when the rigidity gets better, the movement is more easy. But they always thought a negative symptom like bradykinesia cannot be improved by knocking out a certain area of the brain. So they had no idea that there was overactivity in GPI or other basic ganglia. And so Sven-Nilsson and Lexell, they really noted and they published it that there was a clear improvement of bradykinesia. But as with many things, nobody else really took notice of it. And the concept, I think, was buried until we had the new studies on the basal ganglion neurophysiology by Baylor, DeLong, Hager Bergman, and Tibor Assis, and so on. And so the story of the pallidotomy, Parkinsonism in the 1950s is not a story of improving bradykinesia, because nobody could understand it.
Makes sense. And so does it match your impression that around 1960 on a global scale, the pallidum then became abandoned again and the thalamus became the new main target before then later being rediscovered? First of all, is that correct? And then second, why do you think there was a shift to the thalamus around that time?
I think, if I may answer, the paper of Lexell was published in 1960 in a journal that nobody reads. So, number one. Number two, already in 1960, the thalamotomy by Hassler and later by Cooper was gaining momentum. because it is extremely efficient for tremor. And not only that, the thalamotomy, when I say thalamotomy, I say thalamotomy and subthalamotomy, because don't forget many authors like Wertheimer, Andy, Hudar, also Munninger, also included the subthalamic area. Not the subthalamic nucleus, the subthalamic area. So thalamotomy, subthalamotomy were almost the same. And they were very effective for the symptom that you can see on videos at that time or camera, in patients. Not like today on internet, but still there was motion pictures, and this was a very striking appearance that pushed neurosurgeons, including Lexell later on, including Lexell and Leitner and others, to go for the thalamus. The patients had tremor, and also not only that, don't forget essential tremor, post-traumatic tremor, MS tremor, Holmes tremor, all the kind of tremor. So it was a universal target that could help tremor and also, in a way, rigidity. And it helped rigidity not by making the patient normotonic, hypotonic. That's why after thalamotomy you have like a flat tire. The patient has some going to the thalamotomy side, flat tire, I call it, which was described by Albrecht Struppler in Munich. You know Albrecht Struppler in Munich. He died some years ago. Joachim knows him.
He was
described
performing stereotactic neurosurgery.
Yes.
Struppler, yeah.
You can comment. So it was described despite the deviation to the thalamotomy side. It was so striking. Exactly many years later, like when Ben Abid and others show a patient with ST-NDBS dancing and rotating, going around, and this impressed people. So that is, in my opinion, the reason, because compared with the inconsistent effect of pallidotomy. So we neurosurgeons are like sheep. One sheep go there, everybody go there. Now, one sheep go to focus ultrasound, everybody go to focus ultrasound. One sheep go to... So we know that. So that's the reason. Until Leitner reintroduced it many years later. Joachim, can you comment?
No, it's true. It's true. I think that thalamotomy and subthalamotomy in many centers partially replaced pallidotomy. And of course, pallidotomy has some effect on tremor in Parkinsonism, but the effects with thalamotomy is so striking. I mean, the tremor is gone within a second or so, or 2 seconds. And pallidotomy took a longer time, then it recurred earlier. I think when people showed the videos, there were no videos at the films at international conferences showing the improvement of tremor. This was a fantastic improvement, and it was much better than that, seemed much more spectacular than the results seen with pallidotomy, of course.
It just reminds me, just the last podcast episode with Todd Langevin, who was with Medtronic, when they introduced, he led the team to essentially introduce DBS to Medtronic and market it, and he said it was easy to raise money because of the same thing. You showed the video with the tremor stop, right? It just remains a fantastic story to see that, and I think we are all still always amazed when we see that, or at least me, speaking for myself. So I can understand that. So then, quoting from an article by the team of Andres Lozano, they wrote, in 1992, Lori Leitinen rediscovered Lexell's postereventral pallidotomy target after a period of 30 years during which the procedure was almost forgotten. And Marwan, you are the last author on that 1992 paper, which I think reported on 38 patients with Parkinson's that underwent pallidotomy. Could you summarize also what your role was? You were still junior at the time, or
first a small correction to the history paper of fantastic history paper of Joachim, where he writes that the rediscovery of pallidotomy was initiated by Lori Leitinen, neurosurgeon at the Sophia Hemmet Hospital in Stockholm. No, it was in Umeå. The first 13 patients. The first 13 patients, Joachim, were done in Umeå when I was the resident at that time.
Okay.
And the funny thing here is that Leksell and Leitner had a meeting in Stockholm, I think, or somewhere. I was not there. And they discussed pallidotomy and they discussed the Sven Nilsson paper. I was not at that meeting, and Leksell died in 86. On January 30, 1985, 30 January 1985, was the first pallidotomy done. And I was there, and I have video of the patient and pictures. And I said to Leitner, why are you doing this? He said, because this patient has tremor and dyskinesia and this, and we will try it. And I said, why do you try it? Based on what? He said, on the paper that I gave to you last week, the Sven Nilsson paper. Well, at that time, there was no L-DOPA, right? At the time, so we had no idea about what the effect would be on the dyskinesia of the patient. And furthermore, the neurologist who referred the patient, they referred them for thalamotomy. That was the usual referral. They referred patient for thalamotomy. All these patients had also tremor. That's why they were referred for thalamotomy. So Leitner said, let's try this and see what happened. And what happened, and I remember the first patient, no flat tire. The patient don't deviate to the like thalamotomy. The dyskinesia were gone. The tremor was better, but not gone. The patient was happy. The speech was okay. So it was really fantastic. So that was patient number 1. Later that week, we had patient number 2. And then 3 said, and then up to 13 patients before Leitner moved to Stockholm, left Umeå, left me alone there, and went back. And we studied these patients later on, me and Tommy Bergenheim, who has the second name on the paper, with a 10-year follow-up of the same patient. We visited them at home, at the nursing home. And we submitted a very nice paper, detailed, patient by patient, to neurology. It was rejected because we didn't have UPDRS. UPDRS did not exist in 85. There was no UPDRS in 85. So we told them, how can you use UPDRS? You could use it post-operatively. Well, we don't have pre-operative UPDRS. It was rejected by neurology. The same neurology who published the same year Fazzini's paper with 0 UPDRS that I sent you. This is the same neurology journal. Anyway, we published then that in Journal of Neurosurgery, 10-year follow-up, including one patient with bilateral thalamotomy who went back to work as bus driver in northern Sweden. So the story was that the dyskinesia, which was abolished completely by pallidotomy, was a new thing because we didn't know that. And the second thing is that this was done before the model of Alexander Delong. Leitner had no idea about the model of Alexander Delong. Leksell even less. Delong was not born in 1940 or 50. So almost. So it was completely serendipity, completely observation, and it was not based on the circuitry of Alexander Delong, and it was extremely nice for. And then we operated, I think, a couple of patients with dystonia. I have one patient who is not published, and the same thing there. The dystonia was gone, but the effect was not immediate. It took some time for the patient to improve. Joachim, you can comment more?
You mean on the pallidum, the revival of the pallidotomy? I think it had several reasons, as you said, Marwan, but also, of course, what people became aware were the limitations of levodopa replacement therapy. Because initially, of course, in the late 60s, when dopaminergic therapy became popular, it was absolutely fantastic. Yeah? Film awakenings, like it showed, but later people became aware that levodopa also long-term treatment can have side effects like fluctuations, dyskinesias, and so on. And I think that was also one of the big impetus for rediscovering surgical therapies in general. I mean, not only pallidotomy, thalamotomy also came back in a way. But also another, I think, event we must account for is the re-acceptance of surgical therapies in general, because in 1987, Magrazzo started with autologous transplantation of adrenal medullary tissue to the striatum. Then later, shortly thereafter, we had a big public attention for implantation of fetal mesencephalic tissue for Parkinsonism. And I think that really also paved the way, because it was soon realized that it doesn't work like people thought so, and there were problems with it. And that also paved the way to rediscover surgical therapies for movement disorders. And of course, I think your paper, Marwan, just was placed at the right time in the biggest, I must say, neurosurgical journal, the most widely read neurosurgical journal. So I think everyone who was interested in movement disorder was reading this manuscript and got the idea that we are back on track with functional surgery with lesioning.
I must add here two things. One, why was the paper published in 1992 when the first patient was operated in 85? Well, the reason is that this paper was rejected first from the Swedish Medical Journal, who now regretted very much to this rejection, and then rejected a couple of times from a Journal of Neurosurgery. And I remember when I went to meeting, for example, I went to France. I speak French to show the results before the publication of the paper in the late 80s. I was destroyed by Serge Blanc and Jean Siegfried. What is this? It's obsolete. What are you coming here talking about this rubbish, pallidotomy? And I never forget that, because I was a young, still resident at that time. And being attacked by Serge Blanc from Lille and Jean Siegfried for something very obsolete. It doesn't work, what you're talking about, etc. Anyway, so then Lori Leitinen wrote to Thoralf Sant. Thoralf Sant was the great man who was the editor of Journal of Neurosurgery, and asked that he review the paper, not the other reviewers. And Thoralf Sant reviewed the paper and then published it, and it was published in 1992, which is about 7 years after the first patient was operated. Number two, I want to say is that this gained a big popularity, pallidotomy, in the United States and Canada, and in UK, but not in France, not in Germany, because at that time, Monsieur Joachim was in Houston, and published from Houston, the pallidotomy, but nobody did it in France. I helped in France with 3 pallidotomy with colleagues later on, because they couldn't have DBS. So I went there to help with that. But because in 1987, Ben Abid has started the DBS for VIM, right? And 93 for STN. But already in 97, when VIM DBS came, that was what French people did. Germany, I don't know. Maybe there are other reasons why in Germany lesions were not accepted. Maybe Joachim can comment on that.
It's like you say, Marwan. So the renaissance of pallidotomy really was starting on a bigger scale in the United States, North America, Canada, United States, I would say. Yeah? I mean, it was initiated in Northern Europe, and I think you continue to do pallidotomies, but it was not well received in France and Germany. And I must say, in Germany, neurologists were very, very skeptical about lesioning surgery, even about pallidotomy at that time. So it was really not an acceptable treatment to have a lesioning. And these quotes like destructive surgery. I mean, when you ask a patient, do you want to have neuromodulation or do you want to have destructive surgery in your brain? It's clear what people would say. Yeah? And in the United States, the Renaissance started in, I would say, 1991. I can tell about that also. The first modern pallidotomy in the United States, New York. And then only after that, after 4, 5, 6, 7 years, the wave swept over to Germany. And then, of course, we had pallidotomies in Germany by Volker Sturm. And I think also in French we had a wave for pallidotomy, but the waves were much smaller than the big Renaissance wave in Canada and the United States.
So Emory was one big center, right? That also did a lot of pallidotomies with Malon. At least he said that. Or who else were?
Absolutely. Well, maybe I can tell a little bit about the first modern pallidotomy in the United States. And when I was in Houston in the 1995, 1996, I had a possibility to meet Dogali and Berridge. Berridge was a neurophysiologist, Dogali was the surgeon. And according to his accounts, he was working together with Ransohoff, famous American neurosurgeon, and he discussed with Ransohoff about looking for different targets than the thalamus, because the thalamus was the main target at the time. And according to Dugali's account, he said, why don't we go to the subthalamic nucleus? And Ransohoff answered him, well, it's impossible because we know this will invariably cause amygdalism. So maybe you think about another target. And then Dogali heard presentations by, I don't know, by you or by Leitinen at congresses about the revival of pallidotomy, Lexel's pallidotomy, Leitinen's pallidotomy, and said that, proposed to Ransohoff he should do this procedure in New York. And he then talked to Leitinen, and Leitinen came to New York along with Ron Tasker from Canada. And the first modern pallidotomy then was done in December 1991 at the Department of Neurosurgery in the Hospital for Joint Diseases in New York University. And then it very rapidly caught fire all over the United States. And as you said, the next major center, I would say, was Atlanta. And Atlanta, they were the one that they really made microelectrode recording a routine technique. Jerry Witek, Malon DeLong, Roy Bakay, and also other centers in California, Loma Linda, Irvine, and Houston started in 1995. Came a lot of applications came out of Toronto, of course, and of Houston. But at that time, pallidotomy was already quite popular in the US.
Who was the surgeon in Toronto? Was that already Andres Lozano at the time, I assume, or?
Yeah, Ron Tasker also.
Okay. Great. So we should maybe just for the listeners also mention, I forgot to add that Marwan sits currently in Umia again, right? So you where it all started, and we see you in your office, home office there, and because I think maybe some people still think you're in London that may not know you as well. So you moved back a while ago, right, to Umia.
Yeah.
And so I think here the story I wanted to tell about that Rhys Cosgrove told me would fit in really nicely, and I'm apologizing that's a bit longer, but I really think it's a great story. So Rhys Cosgrove is the surgeon here at the Brigham, and together with you two apparently is now also a historian of the WSSFN. And so he told that soon after he landed in Boston as the young attending surgeon at the Mass General Hospital, that was around 1990, a patient knocked on his door in need for help regarding severe dyskinesias, and a pallidotomy should be done. The patient was an electrician and apparently a very nice guy, and his wife, they sat in Rhys's office and they asked, how many of these procedures have you done, doctor? And Rhys said 3. So they were, of course, a bit cautious, and he really seemed to like the guy and told him, the best thing you could do is actually to fly to Stockholm and see Lori Leitinen, who is the person on the globe that has the most experience with this procedure. And for a while, then Dr. Cosgrove did not see the patient again. And then in 1992, the 10th Congress of the European Society for Stereotactic and Functional Neurosurgery happened in Stockholm, and Dr. Cosgrove was eager to attend. His favorite conference, and he also said that Europeans always showed a creative thing, but phrased them in ways that were hard to understand. Interesting quote there too. And it was the beginning of email, and he wrote one email to Professor Leitinen. Could he maybe be able to combine the conference with a brief visit to his surgical theater? And it was exactly that the time where Professor Leitinen had figured out how to accept international patients. So the day of his visit, Hariz Cosgrove enters the operation room and finds his electrician patient on the operation table by coincidence. Apparently this was not, set up. And I think you can't make this up. The surgery went well, and both Dr. Cosgrove and the patient made it back to Boston a while later, where the dyskinesia started again. So Hariz took an MRI and finds the lesions Leitinen made were apparently a bit too anterior in the internal pallidum, and covering the more associative and rather than sensory-motor functional zone. So he sends the picture to Leitinen, who agrees, and a revision surgery is planned. Then Dr. Cosgrove finds a way to make Leitinen apparently visiting professor in Boston, and both doctors do the revision together once more, but this time in Boston. And this time Dr. Cosgrove is operating, and the electrode is entered. A high-frequency test stimulus is applied, under which the dyskinesia suddenly go wild. And that's the main drive home here. So apparently, under stimulation, high-frequency test stimulation, there were dyskinesias that suddenly appeared and became much, much worse. So Dr. Cosgrove, at the time still not as experienced as he is today, becomes nervous and is about to abort the procedure when he hears his Swedish colleague says something like, "This is great. He will be excellent." And Hariz told us this story together here in Boston, actually with Marwan, your successor, Ludwig Srinzo, who was visiting to see focused ultrasound, and fellow neurosurgeon Marie Kruger, whom I interviewed in episode 28. So, and we discussed this case exactly because it showed some proof that a lesion is not the same as stimulation, right? Stimulation led to dyskinesia getting worse. The lesion later helped. Do you share this general experience, or do you have ideas of or experiences you've made where high-frequency test simulations would be very different from a lesion later on? And does it match your experience? Do you have something like that? And I think, Marwan, you mentioned even before that under stimulation dyskinesias can get worse, but then a lesion will help them. Is that true?
Yeah, the case that Hariz Cosgrove mentioned to you is published. I have the paper in front of me. I will send you the paper with the MRI of the old lesion and the new lesion. And Leitinen lesion was probably slightly anterior, but especially too lateral.
Okay.
And the new lesion that you see on MRI is medial, more medial in the GPI to the one. So this case is published by Hariz and with MRI. It's also if you can turn a patient during surgery by stimulation from being off medication or off patient into not being on, but being on with dyskinesia in the leg or in the hand. This is, we have learned, a predictive good sign, in the same way as during STN DBS, you stimulate, or you enter the STN and you stimulate, and the patient who is off medication get dyskinetic. What does this mean? It means that the inhibition is gone, and it's even too much gone. So this was considered a big sign, because that was the same thing we experienced in IMMU, that the patient is getting like this, and happy and talking, and his face is mimic is better, and so this is a predictive good sign for a future improvement in the pallidum and in the STN. I mean, it's the same circuitry going.
Of course. But then the lesion would not produce dyskinesias anymore, right?
No. The funny thing is that the lesion sometimes does not, well, often does not produce, dyskinesia are gone. They are so much gone, the dyskinesia, that sometimes the patient has to increase dopa to get better. It blocks, in some patients I've seen and it's described, it blocks not only the dyskinesia, it blocks the kinesia. So it's so efficient that it may block, I don't know why, but I don't know if the lesion is too big or what happened. So this is what allows patients with pallidotomy to increase their medication when needed without getting dyskinesia. You understand? It's too much. It's very powerful in some patients, not all patients, but in some patients. So this is one of the problems that have been seen with pallidotomy, that you block the dyskinesia, but also you can block the effect of normal dopa on the kinesia. Which, by the way, reminds me of a very nice paper of, among others, Leitinen, from the thalamotomy era. When they did thalamotomy on one side and L-dopa was introduced, the dexterity was better in the non-operated hand than in the thalamotomy hand, the finger dexterity.
Okay.
So even in thalamotomy, and we can see it even today in thalamotomy, that the tremor is gone, but the patient's dexterity is not as good as it was before.
Like fine motor skills, you mean? Yeah, okay.
Yeah. The fine motor skills are not bad, but less good than when the non-thalamotomy era.
Yeah, and that showed that the GPI is a very peculiar target, and it's unlike other targets because, I mean, especially with bradykinesia, you can induce bradykinesia and you can improve bradykinesia both. And it's not always that it's different locations in the pallidotomy. It's in the same location where you can improve bradykinesia as in Parkinson's disease, but you can induce bradykinesia as in chorea and dystonia.
With DBS or with lesioning or both?
But actually both.
But I think lesioning is more efficient than DBS. I mean, if you look at patients who have, for example, status dystonicus, the reports were to cure the status dystonicus, they can kill the patient. You do a pallidotomy. In some Italy and other places, they have published that. And in general, a lesion is more well-placed lesion is more efficient than DBS in general. The problem are the side effects, the bilaterality, etc. And it reminds me of an exchange I have with letter to the editor to Anthony Lang. Anthony Lang wrote a paper that we need evidence-based to see if pallidotomy works for dyskinesia, etc. And I wrote a letter, I said, you don't need evidence-based. You need to look at the patient, compare the pallidotomy side with the other side. The patient comes to your office with dyskinesia on the non-operated side, and I think I sent him even a video about that. So the patient is his own control.
Yeah, sure. So, but maybe I find this very interesting, right? How do lesions compare to high-frequency stimulation? Because as a first approximation, it's the same thing, right? First approximation. I don't say it's the same thing, but we have, as we all know, lesions to the same target as DBS would usually generally lead to the same effects or similar effects. But this case now with that Reese described and you have observed yourself, there it seems different, where high frequency stimulation leads to exacerbation of the dyskinesias, but then a lesion to the same site would stop it. So there might be something to learn here, where, as we know, it's not the same thing, but often they're similar, the effects, but here they seem to diverge. So I would love to hear more, because I think we, not experienced with lesions, but also in general, lesions are not performed that often anymore. So you have all this knowledge and this experience here.
This is one of the issues that made Melon DeLong a little bit, not sad, but thinking about his model. I remember because the model would not predict that these two of opposite effects, right? So the model did not predict that this kinesia will get better. So they introduced some variability to the model. Jose Obeso has written about that, the paradox of... I am not neurophysiologist, I don't know. Maybe Joachim, who's the neurologist, also knows. I don't know.
Well, I think it's like it has been said initially, deep brain stimulation is like mimicking a lesion, functional lesion. I think it's not the right concept. And that's, I think everyone accepts in the meantime that we have such a lot of antitromic, autotromic simulation effects and so on. So it's really differs in many different ways.
Yeah, and I think probably nobody really understands, but I just meant other, like, does it match your experience, or do you have other examples where in the operation room high frequency stimulation led to a different effect than the lesion later on? But it seems that at least you have seen similar stories in the OR as well, right, where stimulation led to more dyskinesias, and is that correct?
Yeah, absolutely. Of course, in a way, it depends on the I would say functional state of the basal ganglia.
Yeah, makes sense. Okay.
Even Andy, when it comes to lesion and stimulation, even Ben-Abid in his first paper on DBS for VIM, for the paper from 1987, he writes, and I quote, "This patient had thalamotomy on one side and he did DBS on the other side." That was the first paper. You remember? Yeah,
I do.
But he writes already, I think, in the abstract, that the stimulation was effective, but not as effective as the lesion on the previous lesion on the other side. Ben-Abid writes that in the thalamotomy. The concept that lesion of stimulation, high frequency stimulation, equals lesion actually applies to many targets. It is the capsule, it is in the pallidome, it's in the STN, it's in the VOP, VOA, VIM, it's in the pallidothalamic tractotomy or tract. It does not apply, of course, and should not apply in the PPN or in the fornix. You lesion the fornix, the patient is demented. The lesion PPN, the patient cannot walk. So this is not exactly the same.
At least PPN though was mostly low frequency stimulation, right?
Driving the PPN, not high frequency. Yeah. The fornix, I don't know what frequency they use, but it's a high frequency.
High, it was high, 130. Yeah.
So in all other targets, actually, it mimics. Now there is antegrade and retrograde, and antegrade and retrograde. What is this? Even after lesion, you have a Wallerian degeneration, right? You have a retrograde. That's how the dorsomedial thalamus was used by Spiegel for psychiatry, because it was published in 1947 by no less than Walter Freeman, the Wallerian degeneration after leucotomy going back to the thalamus to the dorsomedial nucleus.
Yeah.
Again, circuitry.
Yeah, of course. No, that makes sense. Yeah. Fantastic. Okay, so in episode 22 of the podcast, I interviewed Melon DeLong, who mentioned that his team with Roy Bakay and Jerry Vitek had good experience with pallidotomies and carried out the procedure frequently until subthalamic DBS came out. And then Kelly Foote, who I also interviewed in episode 25, told Mike Fox in episode 29 that apparently Alim Louis Ben-Abid attempted to carry out pallidal DBS after his successful VIM series. So not, pallidum first, apparently. This is apparently not well known. The pallidal target did not work as well, and the results were never published, according to Kelly. And once then the Bergman and Benazous papers came out, he rapidly pivoted to the STN. Again, this is hearsay. I'm not sure if this is true, but that's what I heard. And of course, we know that then the STN DBS became history. So, Joachim, I think you were among the first surgeons to implant DBS electrodes into the pallidum, and if I know correctly, the first to do so for dystonia, as in your outlined in your famous 1999 Lancet article that we talked about the last time. do you see a difference in maybe risk profile and efficacy or other factors between pallidotomies and then pallidal DBS?
In 1995, I must say, I attended a conference in Irvine, a 3-day meeting. And this was on, the title was called Pallidotomy, Where Are We? Mm-hmm. And Alim Benabit was there giving a lecture on STN DBS, and many people were kind of in a shock-like state. Like, how can he do this? How can he dare to do this? Yeah? To go to the STN, because everyone was focused on the pallidum. And I remember I even stood up and asked him, who was still young at the time, how can you dare to do this? Don't you have a fear of permanent hemipallism? So on. Mm-hmm. And, of course, this was an early sign, what Benabit showed, that the second wave of pallidotomy would decline, in hindsight, of course. Mm-hmm. Okay, now talking about what you asked me about different
DBS versus lesioning.
Pallidal DBS versus lesion. Of course, especially for dystonia, when you actually need bilateral stimulation, the safety profile of DBS is better than with bilateral lesion, because the risk for speech disturbance is higher with bilateral lesion. With, I would say, traditional methods. I'm not sure if we have improved methods, really being confined to the pallidum and have no spread to the capsule, posterior limb of the knee of the capsule, if that would have this same safety profile. But unilateral pallidotomy, of course, is much easier than bilateral lesions. And with that regard, of course, bilateral stimulation is much more forgiving because you can take care of regulating the intensity for stimulation.
Sure. So that is a great point, and I had one question that I have skipped, and it started with Irving Cooper was a giant of lesional neurosurgery, and now that I know that you don't like him or your mentors don't like him, I should have maybe changed it. But I think he carried out 8,000 procedures, and he was quoted by Kryenbuhl to have said that, I hesitate to sacrifice the same structure bilaterally, no matter what structure that may be. And I think also Hassler and Richert became lightly disappointed with pallidal lesions for rigidity and tremor and mentioned that the risks to damage neighboring targets. And then they sought for alternate targets, the thalamus came about. And I think in the Hassler 1960 Brain article, they mentioned that, that's experience from 560 operations between 50 and 58. They often recommended asymmetric lesioning, so maybe on the left side pallidotomy, on the right side thalamotomy, to avoid side effects. Do you think such asymmetric choices could be a good choice even today? Let's say in the with focused ultrasound or so, to exactly avoid sacrificing the same structure on both sides? I don't know. Can you talk to that, Marwan?
Can I just comment? There is a paper recently from Ukraine, from Kostyuk, about asymmetric lesions. What asymmetric lesions meant at that time was, on one side maybe the thalamus, VIM or motothalamus, on the other side the pallidum. That was what was meant by asymmetric lesions. Today, and this is what Kostyuk from Ukraine published just 2 months ago in Stereotactic and Functional Neurosurgery. Pallidal lesion on one side, thalamic on the other side. What the focused ultrasound people are doing now, or trying to publish, is thalamotomy with little asymmetric. And this I don't understand. If you have one side thalamotomy right in the target with the tremor gone, how can it help in being elsewhere than in that target on the other side? But this is maybe a kind of justification to use focused ultrasound, avoiding side effect and having suboptimal effects. This is another discussion. The asymmetry concerns different structures of the circuitry So, and Cooper, I admire this guy. I mean, you should read his book, The Vital Probe, where he writes that that was at the end of his professional life, when he remarried with a Norwegian beautiful woman called Sissel, and yes, and he writes in that paper how he was so devoted to patient that sometime when the surgery didn't go well, he slept in the hospital next to the patient during night, monitoring himself, the patient, sleeping. How many of us sleep with the patients the night after surgery? And he was very keen on really avoiding side effects. The asymmetric lesion of his was in different structures around this circuitry. If I may just comment on Kelly Foote and Ben Abid. Ben Abid has done pallidal stimulation, and they have published. They have several papers on cognition. They have paper about DBS up and down in the pallidum, how you can increase echinacea down and up by Paul Crack. So they have several papers on pallidal stimulation. And the reason they abandoned is because, of course, STN in their hands were much more powerful. You could decrease medication, etc. Another reason is that Jean Siegfried introduced DBS in the pallidum in 1994. And Jean Siegfried and Ben Abid were not exactly very friends for many reasons. And Joachim, he knows that better than me. We should not talk too much. One is dead, one is not dead. So, but they are not very keen friends. So this is another story.
Okay, I must say something about my relationship to Cooper, okay? Because it's not that I do not like Cooper, this is not true. It's that my old boss did not like Cooper. But
sorry, you clarified that before.
Yeah, if you could see here what I show in the camera, you cannot see.
So Joachim just pulled out a book of Cooper. It's called "The Victim is Always the Same."
It's
the title.
The Victim is Always the Same. It has a dedication to Bunny from Sonny inside, and it's written by Cooper. So
fantastic!
Wanted to clarify, okay?
Can you send me a picture of that book so I can order it?
Of course, I can do so. Okay, and let me say also something about asymmetry. I think asymmetry is important with many different regards, because a couple of years ago we had the concept of dominant basal ganglia. One side would be more dominant than the other. I think this concept has not been followed further. Maybe it's not useful, I don't know. But also, when you think about, for example, you have STN, DBS in Parkinson's disease. And many of these patients will have gait problems later. And asymmetric stimulation, for example, is a great concept to improve or ameliorate the gait disorder. So I think we should still have an eye on asymmetry regarding to stimulation within the same target, maybe using different targets. It's a little bit difficult to really grab the success. Is it better to have asymmetric stimulation than not? But I think we should keep it always in mind and maybe come back to it.
When I read it in the Hasler paper, it feels odd to me, right? If I were a patient to know that my brain is now being asymmetrically targeted, one thalamus, one pallidum, but it may make a lot of sense. And of course, you could also, if there's more tremor on the right side, you could maybe choose the thalamus on the left side. Also, so it could be a great concept also now with FAS, I think. But So moving to that topic, later in his career, Russell Myers actually adopted ultrasonic lesioning of the pallidum or pallidofugal complex, which he first reported at the Harvey Cushing Society meeting of 1958. And I've just interviewed Kullervo Hininen in the podcast as well, who is the inventor of MRI-guided focused ultrasound. So not a focused ultrasound, there's a long history before him, but he really, I think, pioneered the MRI guidance, and which has now become very popular. And due to modern day FAS, pallidotomies have become center stage of attention again. And the New York New England Journal article, first authored by Vibhor Krishna, describes a first trial of fuss-based pallidotomies, and 30% of the participants improved by less than 3 points on the motor UPDRS. So that, in the light of the historical success, seems a bit disappointing, I think. What do you think of this development? First of all, is it a good idea to use FUS for pallidotomies, and maybe why wasn't it so successful?
I wrote a letter to the editor published about this paper, because I find this in a way dishonest. Therefore, because, number one, this is a Insightec driven financed trial, and it's said there. So, number two, the threshold for improvement is put at 3 points of UPDRS per side. This is barely clinically significant.
Yes.
No medication would be approved for Parkinson with 3 points. So by starting that, you show the kind of dishonesty, in my opinion, of this trial. The patients were much less sick in the preoperatively than the pallidotomy, the radiofrequency pallidotomy patients. 32% improved on placebo, as you said. And the improvement of about 25% mean that they report is by one side. So they split the UPDRS, they take away the axial, the speech, and so this whole thing is kind of promoting this tool, focused ultrasound, to do pallidotomy. And one of the authors of the paper, I won't mention who it is, but you know him well. One of the authors of this paper who contributed patients say he will never do a focused ultrasound pallidotomy again. This is way below what radiofrequency pallidotomy. And this push of focused ultrasound, it may have its place for some patients with too much atrophy, etc. But in general, it says that you avoid penetrating the brain with a probe. When was penetrating the brain with a probe a problem? It was not a problem during radiofrequency. It was even less during DBS, where you penetrate on both sides of the brain. So penetrating the brain was not the problem. The problem was making a lesion. Why people adopted DBS, it's because you don't make a lesion and you do it bilateral. So you penetrate the brain on both sides, no problem. Never been an issue. The issue was the lesion. Now suddenly the issue is penetrating the brain. Suddenly there is a shift in mind of many people that this is a big issue. You don't penetrate the brain, but you do a lesion. Well, wait a minute, the lesion was bad. It's non-invasive.
I very much agree with you. Also, the marketing to call it non-invasive is very silly.
Completely. Yeah. And I was one of those who said to Insightec when I met them in London many years ago, when they wanted to put a machine in my hospital, don't call it non-invasive. I used to burn paper with a magnifier when I was a child with the sun, The same like gamma knife. They don't call it non-invasive. People are still dying in Hiroshima and Nagasaki. So
So I mean, one point though, so that maybe it's not the penetration, but for some patients, elderly patients with unilateral tremor, they often go home the same day, right? Yeah. And it seems in the good hands, in the right hands, like with Reese, he did 400 cases here already. I think it can be a fantastic method, right? For some patients. It has its place. Yeah.
I don't say it doesn't have its place, but the inflation is that downloading the side effects, how many paresthesias, permanent or balance problem or other issue. I've never had paresthesia with thalamotomy, and the reason they have paresthesia is because they target DBS, too posterior, where you can avoid paresthesia by activating contacts higher up and more anterior. So they download. Or not download, downplay the side effect, and the effect are not as good as with the. There is no head-to-head comparison yet, but according to the literature, not as good. So, in some patients with atrophy, old patients, they can go home the same day, etc. It has its place, But don't denigrate a method in order to improve, to promote a method. This is what DBS people did. They denigrated pallidotomy. You remember, Joachim? They denigrated pallidotomy in the 90s.
Absolutely, yes. But still, I'm not that negative about these new studies. To be true, I think this is a chance, and we see pioneer work. Yeah? So we're seeing now the third wave of pallidotomy, and I would say you can see it from different angles. I could also say this is very honest how they report it, because they are honest in reporting. They have not such a high efficacy. And in a way, it's also, I mean, you can show your results, of course, in different ways, like you have the total UPDS, or you look at some special part of it. But I would say this is good that people start again to accept on a wider scale lesion surgery. Yeah? But that was not the case for many years. And focused ultrasound, to my opinion, opened now the mind of many people to accept lesioning therapies on a much wider level. Of course, it's wrong to market it like you say. I've seen patients coming here to Hanover, and they ask me, what can you do? We can do BS, we can do radiofrequency lesioning. They said, oh my God, but then you need to open the skull, and why don't you do this incisionless method, which is not invasive? Yeah? Of course, this is dishonest, but I would say reporting its results and exploring the field offers some opportunity for the future. And we do not know where they will end, if it will become routine or not. Maybe you can improve methods. For example, one of my visions would be you can easier repeat lesions. Yeah? So maybe you can have focus ultrasound, I don't know, 1, 3, 4 times in a given patient, depending on the progression of the disorder and so on. I think it's just at the very beginning. So I'm looking forward quite hopefully.
I must say here that the first time I met Monsieur Joachim Krauss was in October 2000 in London at the ESSFN meeting. I was moderating a session and he was talking. And what he was talking about is his experience in radiofrequency pallidotomy from Houston. And I asked him a question, if you remember, Joachim. I didn't know him.
I was very scared. Yeah, I was very scared.
No. I mean, how you have these excellent results. I mean, I still have the abstract. Very nice results of radiofrequency pallidotomy of patients much more sick than what we see now in focused ultrasound, and much better results in terms of UPDRS of medication after. So that was the first time I met Joachim.
Yes,
and you remember. But what I want to say is that the funny thing is that those people who are most enthusiastic about ultrasound are those people who were most enthusiastic about you cannot do anything in the brain without micro-recording. Lozano, Obeso, Rumia, etc. And one of my first questions to Andres at a meeting, a public meeting in Berlin, was he was talking about focused ultrasound telemetry. I said, Andres, what did the micro-recording show? He was angry at me. He was angry at me.
I can understand that.
And not only that, the only target they chose for non-micro-recording focused ultrasound was the only target in the brain that you cannot see. I understand pallidal, I understand STN ultrasound, capsule ultrasound, you name it. The VIM is the only thing you cannot see. You cannot even see it. I mean, now probably with FGATIR,
No, but it's a good point. It's exactly there where micro electrode recordings, even in your view, might make sense, right? So
these are the same people who insisted on micro recording. Now they use no recording, nothing,
and just burn a hole. Yeah, got it.
So in my opinion, this is kind of cheap, fashion. Don't forget, fashion is very important. In the decision making today, fashion and yesterday is very important. And we are cheap. I want to have a focused ultrasound. Patrick Blomstead, my boss, is looking to financing focused ultrasound because that's what the patient wants, because that's what they see on. And then you hear them saying that, oh, we offer the patient anything. We have gamma knife, we have this, we have this, we have that. Well, take a patient, tell him or her, we have two like this penetrating the brain down, and we have one, we don't touch the brain. What would you choose?
Sure. Yeah.
I mean, come on.
So I want to also maybe add to what Joachim said. When I read the New England Journal paper, I was not impressed by the results. So I think it was maybe more honest reporting. So, but the question was, and maybe that goes to both of you, why was it not as good? Is it because it's hard to focus the field? I think it's, in the center of the brain, of course, we can focus much better. Is it because the targeting was off? But because in the end, it is a lesion, right? So it should work. Why do you think it did not work as well?
The temperature need to be higher.
Okay.
Because when we do radiofrequency telemetry, we use 70 degrees. When we use radiofrequency pallidotomy, we use 82 degrees. And the temperature in the focus ultrasound cannot get so high.
Okay.
I think they were also cautious, which is okay.
So they could have burned bigger lesions, you think?
Takes longer time.
Longer time, maybe repeat it. Why not? But anyway, I think it's good when you start with a new concept, better be cautious, because when you're not cautious, the whole concept will be killed.
Of course. Yeah, that's a good point. How does focused ultrasound compare to, in your opinion, to gamma knife, which was pioneered by Lexell, and or maybe LIT or other forms of lesioning that are not radio frequency? Any opinion there?
Joachim, opinion?
Well, it depends on what you have at hand also. I think there's nobody who has a machine park like having gamma knife, focused ultrasound, radio frequency, just everything at hand. And so I think it's not that one method is definitely better or worse than the other, but it depends on your health system, on your insurance system, financing,
sure,
and so on. So this is very multifaceted problem. And I think, the time is fortunately over when we had this debate like 20 years ago, EPS or lesioning, one is a good guy, the other is a bad guy. And I think we should just allow to have more instruments available, and maybe you have some patient you could either do this or that, but depending on your location, where you are and what you have to do.
I mean, focus ultrasound, you have immediate results. Gamma knife, you have to wait 6 months. Focus ultrasound, you have immediate MR verification. Gamma knife is more comfortable because the couch of Elekta is more comfortable than lying on the MRI couch. So probably this. But I want to insist, and maybe Joachim will agree or not, today and still for the foreseeable future, the gold standard of lesioning is radio frequency lesioning.
Yeah.
Because this has the most extensive documentation all over the place and totally all over targets. And when you learn how to do a lesion, I mean, I know people today, I have heard that in the US, you have neurologists buying a machine, radiologists buying a machine, people who have never done a lesion buying machines to do focused ultrasound. So, I mean, it's not like it should be.
And they all use DTI to guide them without maybe having ever worked with tractography either. Yeah.
And which tractography? What kind? You have different kinds of tractography. I learned from Hariz.
Exactly.
You don't have only the deterministic and the probabilistic. You have tracts that look as thick as 2 fingers like this.
Yes.
Look at the DRTT of Kernan or the medial forebrain bundle. It's like half the brain. Where do you target there?
Exactly. Yeah. It's scary. I think it's scary too. I think it has to be in the right hands. With Hariz is a perfect example because he has a long history of also doing radio frequency ablations, and he has now done again 400 cases. That is great, I think. But I totally agree. You need to optimally have experience with conventional lesioning. do it right.
Yeah, I think so. And you can monitor the patient much better during radiofrequency than the patient lying with the frame on the head fixed in the MRI. The intraoperative monitoring, not micro-recording, the clinical monitoring is much easier.
I would add micro-electrode recording.
Yeah, you can add if you want, but the monitoring of the clinical result during surgery, prior to radiofrequency lesioning, when you stimulate the patient count backward, you see if the tremor is enhanced, many things. You can monitor everything except walking.
That's a good point, right? You can test stimulate, and they attempt that in FAST 2, but I think if you test stimulate too often in FAST, then you lose the opportunity, right? Because something in the skull changes. So I think you cannot test as long as you want. And some even don't test at all because of that reason, right? Because then, so that's a clear advantage of radiofrequency ablation. So this year, last year, we postponed the podcast. Last year, I co-authored an article in Brain with Juho Jutsa, Neil Lipsman, and Reese Cosgrove, and Marwan, and Mike Fox. And Marwan, you did email us about it too, and it was entitled "The Return of the Lesion for Localization in Therapy." And it was Mike Fox's idea to make the point that both in neuroscience, where you have early lesions like Paul Broca and Wernicke and so on, they were very important. They lost some sort of interest when fMRI came around, but now they are back with lesion network mapping and so on. And lesions are still the most causal way of informing us in neuroscience. But then also in therapy, the same kind of happened, maybe where lesions were, of course, the beginning of stereotactic surgery, but then may have declined a little bit, and then now have a comeback with MR-guided focused ultrasound. And DBS maybe was a stepping stone in between. And the way we kind of see it is that lesions might surpass DBS again. And in order to do that, we need to know better exactly the target and also be able to identify the target in the individual brain very well. And then, of course, have techniques that really hit that spot precisely. Because one of the big advantages of DBS is that we can change it, right? We can adapt it. If we kind of miss the target, we still have a lot of wiggle room, but with the lesion, it's permanent. But maybe as soon as we have better imaging, better ways to identify the sweet spot in individual patients, maybe then lesions again surpass DBS. And so I think you at least you agree that the decline of lesioning was not a good development. And maybe you can comment on the future of ablative neurosurgery, both of you, if you want, as a final question.
The introduction of the new tool without opening the head to make lesion will make for the foreseeable future this to be the future of surgery, partly at the expenses of DBS. But like with all new discoveries, you have this QRS curve. Now it's a big enthusiasm, and then it will be, people will start to having thoughts about the side effect, etc., etc. But as long as there is an economic incentive, financial incentive, promoting meetings, it's like with DBS. I couldn't afford to go to meetings during the pallidotomy era. There was no incentive. And then DBS came, and you get invited here and invited there, and they pay your trip. And I had to say no sometimes to trip to Las Vegas because of the Neuromodulation Society and this. I said, no, to Medtronic. I don't want to go to Las Vegas. It will be disaster for me.
Okay.
So now, depending on how this promotion of meetings and travels and this, and I'm not saying that this is something bad. I mean, we need also the industry to but don't neglect this issue. There is no money in radiofrequency lesioning. There is money in deep brain stimulation, and there is money in focused ultrasound. And this will be something that will maybe move the field more towards lesion with the latest machine, together with the so-called non-invasive or incision-less, together with, but this, and I insist, will be at the expense of less efficiency, more side effect. Read my word, less efficiency, more side effect than with radio frequency or with the, and already we see permanent paresthesia, permanent this, permanent that, in few, but still some patients. This is my, Joachim, your opinion.
Okay, well, we all don't know what the future will really bring, and of course it would be better if we have disorders actually to prevent them or to treat them in easier medical way. But that is a dream of every kind of disorder, brain tumors, whatever. Yeah? And for the time being, I do not see this development in movement disorders. Also, we know much more about genetics now, yeah? But still, I think what will be in 10 or 20 years, will surgery be gone? I don't think so. Yeah? And the time of acceptance of lesioning has already begun since 5 or 10 years. And we're already in the middle of that third wave. And I think it will become bigger. We will see more lesioning surgery. Maybe we will have more radiofrequency lesioning again, in places where you don't have a full machinery. But also, I do not think that deep brain stimulation will go down completely, because there's many indications, especially about bilateral surgery, and I'm still, I must say, more skeptic, of course, when I look at bilateral surgery for many movement disorders like dystonia with fast machinery. Yeah, so I think in that case we were still on the safer side with deep brain stimulation also, and that has become an accepted treatment. So for the next 10 or 20 years, I would say we have parallel developments. We will have a lot of discussion what is better or worse. We will always have heated minds sometimes who think this is right or this is wrong. But I would say when you've been long enough in this business and you've seen 30, 40 years what has been going on and going down, you should also look at it in a more relaxed way.
What you just said, one I think key advantage of DBS that is not often talked about is also the disease progression, right? Often the first symptoms are more on the tremor side in Parkinson's, for example. Maybe then a dorsal contact is the best choice, but then maybe over time, axial symptoms and freezing of gait become more, in the front, in the center of the disorder, and there it's, we cannot do as much, but maybe a more ventral contact will be more great here, and so that's a beyond not maybe that you can, if you slightly missed, you can still mitigate it. That's one advantage, but also the time domain, right? Where a lesion, you cannot change the lesion. You could do another one, but maybe that's another key advantage of these more adjustable systems like DBS.
Yes, and there's also very little flexibility switching from one method to another method. As you say, as a disorder progresses, you have different symptoms at different points of time. And maybe for some of these symptoms, the lesion would be better later or earlier. But usually we don't think in these categories. We usually think it's either brain stimulation or it's either lesioning. But there's very little exploration in combining concepts.
Although that, as Marwan said, that's how it started in '87, right? With the first report where the one side was lesioned and one side had DBS.
That's true. That's how it started.
Yeah.
And we shouldn't forget also the financial issues. Focus ultrasound is expensive. DBS is even more expensive. Radio frequency is the same electrode you can use hundreds of times. It's not expensive. So think about the population in the world that cannot afford, that may need surgery but cannot afford to have these very sophisticated tools. And
absolutely,
there is a risk for loss of skills. I mean, the generation of people who know how to do lesions with radio frequency is either retired or demented or dying, with few exceptions. Right, Joachim?
Thank you, Marwan.
So, so we don't train young colleagues in doing radio frequency lesion. That's how I trained. That's how Joachim trained, and Hariz trained, and Andres Lozano, etc. But who is coming then? How will they do this? I mean, it's like with aneurysm. You know, if you coil everybody, nobody will know how to clip an aneurysm anymore, right, Joachim?
Yeah, it will be rediscovered. So
we have Harith Akram, right? That you trained, and I think he's young and does lesioning with RF in London.
Yeah, I trained Ludwig and partly Harith, and they are doing lesions both with radio frequency. Ludwig does it in Malta and even in London, publishing that, using new methods to target with the tractography a la Harith, not a la Kernan, a la Harith, which is different. Yeah, but they know how to do it, and they are young, but they're exceptions.
They're exceptions. Yeah, I agree. And they
how
have
many in Germany? How many in
now.
Germany, in Charité or Hanover, or even other places? How many can do radio frequency lesion and feel confident with that?
Yeah, good question. I think Veerle Wisse-Vanderwalle, I think, does some RF. No? Okay.
Yeah, I'm training residents here to do pallidotomies still. So I have two neurosurgeons now besides me who can do pallidotomies.
Great. I agree. It's great to keep that knowledge around. Absolutely. That's very important. Okay, so I want to be mindful of your time. We already spent, I think, over 2 hours now. Sorry to go over time. Any maybe thoughts about the future, or also questions we did not cover before we wrap up? Anything we should do, or missed opportunities in this field, or final words that you wanted to say to end the conversation?
I want just to say that it's very courageous of you to spend time with these pods that you have done now, about 50, right?
Almost, yeah.
And we learn a lot, and you probably learn something.
A lot, yeah. That's the main reason I do it.
Yes, and this is a great honor for me to have. This is second time. I was one of the first they interviewed. I was quite angry at that time because I had thyrotoxicosis, if you remember, on cortisone, and was. But
it was a great episode, though. Yeah.
Thank you very much.
Thanks for joining.
And thank you for associating me with the great man, Joachim, former president of the society here and society there, and big colleague and a big friend.
Well, I must say this has been a pleasure again. And I think it's great what you're doing with this podcast, because this is kind of open history. And now with having this on the internet, gives it a completely different aspect, because it will stay there for much longer time than like the video formats we had earlier. And I hope to keep on going with this format. There are more people to come later. And this today, it was again a pleasure to talk with Marwan. And I know I even didn't notice how time goes by. Yeah, we could talk about this for hours, I think, and we always discover something new. And as we said before, it's very important to have a look on history, because otherwise you will cover everything at one point in time.
Yeah. No, absolutely. But sorry.
Congratulations to your very successful series.
Oh, thank you. But thanks again. Also, maybe I can share that. How busy you are. And then taking 2 hours or even more than 2 hours is really fantastic. And I know how busy you are, not just because you're so famous and everything, but we had to find an appointment twice, and it was always, I think, planned for 3 months or so, something. Planned to do it in December and then had to postpone, and then that just shows how hard it is to find such a slot with you. And so thank you even more for taking so much time to do this. I learned a lot, and it was fantastic to talk to you. Big honor. Thank you.
Thanks a lot. Bye-bye.
Bye-bye.